Good morning, everyone, and thank you to SAGES for the invitation to speak this morning. Obviously, thank you to the moderators. Pleasure to be here. My name is Salvatore. I'm going to be presenting some data demonstrating that visceral adiposity actually can predict some of the acuity of diverticulitis. Go forward here.
Need some help.
Next slide, please. Let's see. There we go. This should work. All right. So I have nothing to disclose. Some background information. 5% of the U.S. population by the age of 40 will have some demonstration of diverticulosis, diverticulitis. With the population being approximately 300 million, that can be rounded off to nearly 15 million individuals who are at risk. And by 65 years old, that percentage can increase up to 65%. And diverticulitis plays a large component of admissions to hospitals, with in 2010 having over 800,000 admissions and nearly 3,000 deaths. Now, recent associations have demonstrated that obesity does play a role in defining complicated diverticular disease. Significant associations have been demonstrated. However, in terms of defining visceral adiposity, radiographic measurements, quantitative measurements, have become the gold standard for assessing the amount or the volume of visceral adiposity. And for the most part, our purpose alone for this study was to demonstrate if the level of visceral to subcutaneous ratio does play a significant role in determining the potency of diverticulitis. Our methods were fairly simple. We performed an ICD-9 code evaluation using the terminology diverticulitis, diverticulosis, and sigmoidectomy. The study was performed from 2010 to 2015. That time period was significant to the fact that we had radiographic images going back to those dates. So first, once we confirmed diverticulitis using radiographic measurements, we then determined which individuals went for surgery directly from the emergency room after being diagnosed with diverticulitis, and those who underwent elective sigmoidectomy. And they were placed in two groups. One was the emergent group, and the second was the elective group. And here, this is the methodology that we did use in order to perform the measurements of visceral fat and subcutaneous fat. Utilizing our CRXX DICOM program, we set the Hounsfield units to -190 and -300. That is the value significant for fat or adipose cells. And at this point, what we would do is we would create an outline here which would block out the visceral component. And by clicking on the exterior portions, it would calculate the area of the subcutaneous fat. Similarly, in this component here, in order to calculate the visceral fat, we would create an outline as well. And then by simply clicking in the middle portions, the adipose cells will then also be measured, and it will give us two types of volumes. Once we obtain those volumes, we simply obviously create a measurement of the visceral to subcutaneous, and we get a ratio. Most of the literature demonstrates that a VS ratio of 0.4 or higher is indicative of an individual being classified as being obese. For our results, we had an emerging group of 34 patients. The elective group was 32 patients. Our average age was slightly significant, but I think most importantly, which we'll stress here, is that the BMI between the two groups, the emergent and elective group, were not statistically significant. Comorbidities, for the most part, between the two groups were fairly well controlled as well, with no significant differences between the comorbidities for the two groups. Looking at our results, we note that, again, the BMI between the two groups were not significant, but most importantly, I think our ratio, the VS ratio between the emergent and the elective group were statistically significant. So looking at the results of our length of stay, some of the findings were obviously well expected. The emergent group had a significantly longer length of stay of 16 days compared to 5 days, and the complication rate as well was significant. The complication rate is really composed of what was normally could be expected in terms of fairly broad. We classified those as pneumonia, some additional leaks as well, even DVTs as well, and also readmission rates. So what is the importance of these findings? For the most part, in terms of our discussion, we're just going to look at some of the underlying literature. Majority of our findings obviously are clinical in nature, but if we look at some of the bench work that has been done, visceral opacity, of course, has been demonstrated to be associated with diverticulitis, and recently Nagata and colleagues demonstrated that a higher concentration of luminal methane gas has been associated with obesity. And it's theorized that this higher level of methane gas can actually lead to decreased transit time, which can certainly increase the intraluminal pressure, leading to development of diverticulosis. Now, also looking at diverticular bleeding, visceral opacity again has been associated with higher levels of vascular endothelial growth factor as well. And Nagata and colleagues also speculate that the increased levels of VEGF has led to abnormal angiogenesis, fragile vessels, and a higher propensity for rupture as well. And lastly, looking at visceral opacity and the complicated diverticulitis as well, our findings could certainly be associated by the fact that higher levels of visceral fat has been associated with chronic inflammation. Bench studies have shown that adipose tissue has been known to secrete cytokines such as tumor necrosis factor alpha and also interleukin-6, which have shown to play a significant role in inflammation. So certainly it could be demonstrated that visceral fat can play a role in the severity of the inflammatory process for those who have underlying diverticulosis and diverticulitis as well. And then also looking at visceral opacity and its role with atherosclerosis, again, some bench studies have demonstrated that atherosclerosis is attributable and associated with higher levels of visceral fat, and that is also believed to predispose individuals to having rupture. So those obviously can also be, these findings can be extrapolated to our study as well, which can be thought of as having, in those individuals who have higher levels of VS ratio or visceral fat, can have a higher incidence of atherosclerosis at the dome of the diverticulum, which can lead to a higher risk of perforation as well. And then just in some nearer conclusion here, some limitations of our study, obviously our study is retrospective in nature. We do have a smaller sample size simply based on the fact that we needed fairly recent radiographic measurements in terms of nearing the emergent surgical procedure and also the elective procedure as well, which kind of limited our sample size for the most part. And now finally, what is the role or what is the importance of these findings? The question is, obviously we have some previous radiographic measurements or classifications, and the next question is, should visceral opacity become another factor in terms of determining how we proceed with these patients? Again, there's clinically significant demonstrable appearance that higher levels of visceral fat can be associated with a more potent presentation of diverticulitis. And again, patients with higher levels of VS ratios are more likely to undergo emergent versus elective surgery for diverticulitis. But most importantly, obviously, further retrospective studies need to perform in order to see what is the clinical significance of these findings. And then having been trained in the area of bariatric surgery, I guess one of the questions that I find interesting is there a role for bariatric surgery in this population? For individuals who have been diagnosed with diverticulitis, for those individuals who undergo bariatric surgery, there's been shown a reduction in visceral fat, and would this actually have some benefit in this patient group? Thank you very much. Appreciate it.